Thank you so much, David. It's a pleasure to be here. I always enjoy coming to this conference and getting the debates and updates in GI malignancies. So what I hope to do today is to give you a little bit of update on what's happening in the major GI cancer predisposition syndromes, and I'll focus on pancreas cancer, gastric cancer, and also colorectal cancer, on what genes are implicated, who should get tested, and how do positive genetic test results impact the management of our GI patients. I will also talk a little bit about multi-gene testing and some of the benefits and also some of the disadvantage of this type of testing. So in terms of genetic risk assessment, we certainly know that it's extremely important throughout the course of the oncological treatment of our patients. Certainly it has an impact on pre-surgical decision-making. For example, in Lynch, you may do an extended colectomy or an FAP. The germline mutations often have predictive and prognostic implications during treatment. For example, in Lynch-associated colon cancers, obviously, there's implicated prognosis and even response to certain chemotherapies that are emerging. And then in patients who are cured of their cancer, obviously there is cancer prevention, including risk-reducing surgeries that sometimes need to be undertaken, as well as surveillance measures that may need to be increased based on the presence of a germline mutation. So this also has implications for the at-risk family members who may also benefit from increased screening and surveillance, and hopefully from avoidance of a cancer diagnosis. So I'm going to start with pancreas cancer today because I think some of the highest impact papers have really come out in pancreas cancer susceptibility over the last few years. It's long been acknowledged that family history of pancreas cancer is one of the strongest risk factors for pancreas cancer, with patients with just one first-degree, with individuals with one first-degree relative with pancreas cancer having an increased risk of about 6% lifetime risk. And as the number of first-degree relatives increases, you can see that the lifetime risk of pancreas cancer significantly increases. Our understanding of what underlies the germline susceptibility for this is still not exactly clear. However, we do know that pancreas cancer is a component of many cancer predisposition syndromes, some of which are listed here. And I would like you to focus on BRCA1 and BRCA2, also Lynch syndrome. Pancreas cancer is certainly implicated in that, as well as PALB2 and ATM mutations, which have traditionally been associated with breast cancer, but clearly there's also an increased risk of pancreas cancer with these genes. Now, what's important is most of these studies actually are based on family studies, so it's looking at families that are positive for one of these mutations and looking at the prevalence of pancreas cancer in those kindreds. But what has become more apparent over the last 2 or 3 years is that there is an increased risk of germline mutations, even if you're just looking at pancreas cancer patients themselves. So our group has demonstrated that about 6 to 14% of individuals of Jewish ancestry with pancreas cancer harbor a BRCA1 or BRCA2 mutation. And based on this, NCCN changed their recommendations to recommend BRCA1 and 2 founder testing for all patients with Ashkenazi Jewish ancestry and pancreas cancer. And then more recent data on unselected pancreatic ductal adenocarcinoma patients found increased rates of mutations of 4 to about 14%. And there was the Memorial Sloan Kettering publication in JNCI just recently by Mayflowery and Dr. O'Reilly, as well as a number of other publications. And what was also interesting is that age is not necessarily predictive of germline mutation status. So this is different from the other syndromes like colon cancer, where early onset colon cancer, you do find higher rates of mutations. This is not necessarily the case in pancreas cancer. And so the current NCCN criteria, as I mentioned, are AJ ancestry with pancreas cancer. They need to have BRCA testing, or those patients with pancreas cancer with family history of an HBOC-related cancer. But what has come to the forefront is that I'm not sure that we're truly capturing all of the germline mutation carriers. Specifically, in our JNCI study, we found that 40% of germline positive pancreas patients did not meet current clinical testing criteria. Moreover, the homologous recombination deficient related pancreas cancers may have increased sensitivity to platinum agents. potentially increased response to PARP inhibition, which I'm sure Dr. O'Reilly will address, as well as some of them, the pancreas cancers are MSI and may have implications for use of checkpoint inhibitors. So our group, as well as Matt Yergelin from Dana-Farber, have voiced their opinions with respect to our recommendation that we should actually lower our threshold for germline genetic assessment in pancreas cancer. And in fact, we are recommending that now germline assessment be done on a universal basis in pancreas cancer patients. And I think in the next 1 to 2 years, NCCN, based on these publications, will likely change their guidelines to incorporate this universal testing. This is not new in the world of genetics. Universal testing in ovarian cancer for BRCA1 and 2 was incorporated back in 2007. As you know, in colon cancer, we are also recommending universal testing for mismatch repair deficiency, which I'll review in a minute. So moving on to gastric cancer, similar to pancreas cancer, gastric cancer has been known to be a component of many different types of cancer predisposition syndromes. Namely, I want to highlight Lynch syndrome, obviously because of the importance of checkpoint inhibitors in the metastatic gastric cancer patients, as well as BRCA1 and BRCA2 and the emerging evidence that these two genes are associated with gastric cancer predisposition. And then last but not least, probably the highest lifetime risk of gastric cancer is in patients with hereditary diffuse gastric cancer associated with CDH1 mutations. And just to focus on this subset a little bit, so these criteria for when to consider CDH1 testing are very similar to the old Bethesda guidelines that we used for colon cancer. You have to have 2 cases of diffuse gastric with one under the age of 50 or 3 diffuse gastrics in the family independent of age, or early onset diffuse gastric cancer, which is less than 40 in this particular group, or a personal or family history of diffuse gastric and lobular breast cancer, which is a known component of cancer in this particular syndrome. So gastric cancer risk is very high in these patients, probably higher in women than men, and there's also a significantly increased risk of lobular breast cancer, about 40 to 50% lifetime risk, similar to what is the risk in BRCA2 mutation carriers. In these patients, prophylactic gastrectomy is the recommended surgical treatment option. I'll show you why endoscopy doesn't work in a minute. And we also recommend enhanced breast cancer screening with annual mammograms and MRIs, similar to what we do for our BRCA population. Some patients do choose bilateral prophylactic mastectomy, which is also not unreasonable. So unfortunately, endoscopy really does not work in this disease. This is a 10-year-old paper now showing 8 total gastrectomy specimens. These were patients all with CDH1 mutations who underwent endoscopy screening and were not found to have any cancerous lesions in their stomach prior to surgery, but upon surgical resection, when the pathology was looked at very closely, all the little yellow stars indicate different foci of signet ring cells. So clearly endoscopy does not work in this disease. We updated our outcomes on our CDH1 positive patients. This is with Vivian Strong and Dan Coit, who do the vast majority of the total gastrectomies at Memorial. And we unfortunately also found that patients undergoing prophylactic total gastrectomy, 85% of them had 1 or more foci of intramucosal signet ring cells. So again, this just reinforces that if you have a CDH1 carrier who is unaffected, a prophylactic gastrectomy is recommended. For those with gastric cancer, limited stage, obviously, a total gastrectomy is the recommendation. Now, moving on to colorectal cancer, we know that the most common inherited cause of colorectal cancer is Lynch syndrome, accounting for about 3% of colon cancers. An additional 1 to 2% is other rare syndromes like FAP and some of the newer genes that I'll mention. So Lynch syndrome, as we all know, is autosomal dominant, early onset colon cancer, right-sided predominance. Now there are 5 genes associated with Lynch syndrome: MLH1, MSH2, MSH6, PMS2, and EpCAM deletions, which are just upstream of MSH2. What's interesting is that data is emerging that MSH6 and PMS2 not only have lower risks of cancer, including colon cancer, but also are probably more prevalent in the population than MSH2 and MLH1, which are the traditional higher risk mutations. These are some of the cancer risks in Lynch versus the population, and what I highlighted in red is that in addition to colorectal cancer, you see that there is an increased risk of stomach, hepatobiliary tract, small bowel, and pancreas cancer. So for all of us that treat GI cancer patients, this syndrome is really relevant, especially given the role of checkpoint inhibitors in this population. So in terms of defective mismatch repair, we know that about 15% of all colorectal cancers exhibit mismatch repair deficiency. In the vast majority, probably 75% of patients, this is actually an acquired somatic event, usually due to methylation of the MLH1 promoter region. And this is a somatic event, not inherited. However, in about 3% of all colorectal cases, this is due to a germline mutation in one of the mismatch repair genes. So who do we screen for mismatch repair deficiency in colon cancer? Well, we used to have the Amsterdam criteria, then the revised Bethesda criteria, but this has all become very simple. The current recommendation by NCCN is universal screening of all individuals with newly diagnosed colon cancer for mismatch repair deficiency. There are basically two different ways of screening. Immunohistochemical staining for the mismatch repair proteins, where if the protein is expressed in the tumor, then the mismatch repair process is intact. If it's absent, then it designates a tumor that's mismatch repair deficient. Or you can do the traditional microsatellite instability analysis using PCR-based methods where microsatellite instability in 2 or more loci is a marker of MSI high. The concordance between these two is pretty good at about 90%. I usually rely on one or the other. At our institution, we generally start with immunohistochemical staining. If IHC is normal, then basically no further testing is warranted unless there's obviously a very strong family history. If there's loss of MLH1 and PMS2, then we usually do either BRAF V600 assessment or promoter hypermethylation testing for MLH1. If that's present, then you basically have ruled out Lynch syndrome. If it's absent, you really need to refer to genetic testing and genetic counseling. If loss of any of the other mismatch repair proteins is present in the tumor, then we usually go direct to germline testing. So the recommendations for our Lynch patients in terms of colorectal cancer risk, we recommend annual colonoscopy that's at our institutions, but at the NCCN guidelines say every 1 to 2 years, and I think most of the Europeans do every 2-year colonoscopies starting at a very early age. There is data from John Burns from UK that aspirin does lower colon cancer risks in these patients, as well as the possibility of extracolonic cancers. Risk-reducing colectomy may be undertaken. The majority of our Lynch patients do not undergo this option, even if they know they have Lynch and they have to undergo a segmental resection. But it's a little bit cultural. I know in other institutions there's a higher uptake of total colectomy. For gastric cancer, no effective screening has been demonstrated, but certainly EGD we do every 2 to 3 years usually. For endometrial and ovarian cancer, obviously there is no good screening for either one of these, and risk-reducing hysterectomy with bilateral salpingo-oophorectomy is recommended at the completion of childbearing. For urinary tract, again, no efficacious screening. We do urinalysis, looking for microscopic hematuria. Other institutions do urine cytology, but again, it's not proven to be efficacious. The highest risk of urinary tract cancers is really in MSH2 carriers, especially men, especially smokers. So it's those patients that I worry about the most. So what has emerged over the last few years is there's really an increasing need for MSI testing in colon cancer and actually in many different cancers, especially those that are metastatic. So now we recommend universal testing for colon as well as endometrial cancers because of the high prevalence of Lynch syndrome in this cohort. In early stage colon cancer, obviously it's needed for pre-surgical decision making as well as prognostic and predictive impact, which I mentioned before. And then in metastatic colon cancer, there's a very important role for microsatellite instability in terms of identifying patients for checkpoint inhibition. In addition, with the approval of pembrolizumab for all MSI-high metastatic tumors, we are increasing MSI testing across all metastatic tumor types. And so this is sort of a good time to bring up the potential use of next-generation sequencing assays for determining microsatellite instability. This is our in-house MSK-IMPACT panel, which has 468 cancer genes on it. And from the next-gen sequencing data, we can infer microsatellite instability through a bioinformatic tool called MSI Sensor. And what you see here are the cancers listed for about 10,000 patients, and the top two are certainly colorectal and endometrial cancer, but a score above 10 designates any other MSI high tumor. And you see that in addition to colon and endometrial, there's MSI high in prostate, bladder, esophageal, gastric cancers, pancreas cancers, so a number of other malignancies that you don't traditionally think about. This has very important implications in terms of treatment for these patients. I also think that applying this NGS pipeline is quite efficient because you get the molecular genetic test results that you need. For example, KRAS, BRAF for your colon cancer patients, in addition to microsatellite instability. And we're in the process of switching from our frontline IHC testing for our colon cancer patients to MSI testing via this NGS method. So colon cancer susceptibility testing used to be very easy in 2010. You either fell into the Lynch category, the adenomatous polyposis category, or the hamartomatous polyposis category. And usually when we did genetic testing, we did single gene or sequential testing. And it was very much phenotype driven. However, in 2008, the spectrum of colon cancer susceptibility genes that have been discovered is much more broad. You see the addition of EpCAM, you see POL-E, POL-D1, which result in high mutational load associated cancers. POL-D1 is also associated with endometrial cancer, and both POL-E and POL-D1 have high rates of adenomatous polyposis. Gram-1 we usually see with mixed polyposis, and usually in patients of Ashkenazi Jewish descent, and a number of autosomal recessive colon cancer susceptibility genes are also emerging. Because of this, and because of the ease with which we can do multi-gene panel testing via NGS methods, what we have come to realize is that simultaneous analysis of a set of genes is quite easy and maybe a little bit more efficient. So this is not necessarily phenotype-based testing. And what you see is some of the commercial companies with the different genes that are listed. What's important is in addition to the high penetrance genes, you also see the lower penetrance genes that are listed, or moderate penetrance genes, where the colon cancer risk is maybe twofold. So what are the findings from this? So this is a nice study by Matt Jorgelin at Dana-Farber. They took 1,000 colon cancer patients and applied a 25-gene panel to all patients, irrespective of family history, finding that about 5% had a high penetrance mutation, 3% Lynch, as expected, 1% BRCA, but it's unknown if they were really BRCA-related tumors or just incidental findings. And then another 4% had moderate penetrance genes, where the implications are really unclear at this point. So we also have a similar germline assessment based on our MSK-IMPACT. Of the 468 genes that are on our IMPACT panel, we're now assessing the germline in 88 of those genes, which have been related to cancer susceptibility. And you can see some of the genes highlighted in blue are the ones that we test for. And in our first 1,000 patients that underwent this 88 gene panel, across different tumors, we found that about 17% had a clinically actionable mutation, with these actionable findings leading to a change in therapy in nearly 20% of cases. Specifically, when we looked at colon cancer, we had a total of 427 patients. About in the early onset colon cancer group under age 50, 7% had Lynch syndrome. This is consistent with other data suggesting prevalence of Lynch of 7 to 8% in early onset colon cancer patients. But we found a number of other high penetrance mutations, which we are looking to see if the tumor also has loss of heterozygosity in those particular genes, suggesting the etiology of the tumor due to the germline susceptibility. So what is the case for multi-gene testing? Well, I think it's certainly efficient. This is sort of a demonstration of a case where it's much easier to recognize a certain genetic positive test result. This was a patient with a ureter and a colon cancer at a young age, stage 2 obstructing sigmoid tumor where the mismatch repair proteins were all intact. The patient also had 16 tubular adenomas and 3 to 4 hyperplastic polyps. And we did a multi-gene panel and ended up finding a POL-E hotspot germline mutation. And this is certainly not the first test that I would have run in this patient. I was very suspicious for Lynch because of the presence of ureter and colon cancer, and lo and behold, it was a POL-E1 mutation that caused this patient's cancer. So clearly, this is a case for multi-gene testing. However, incidental findings and variants of unknown significance complicate such multi-gene testing. So this is a patient I saw who had rectal cancer at age 51. The mismatch repair proteins were intact, and she underwent a very large, extensive multi-gene panel. And she had a CDH1 alteration. I call it an alteration because one laboratory called it a likely pathogenic variant, another one called it a variant of unknown significance. And we segregated this to the cousin who had breast cancer, which happened to be lobular breast cancer, again, suspicious for possibility of CDH1, the same alteration was found. So, but what you see is a lack of gastric cancer family history in this patient. So what do you do in an individual like this who's cured of their rectal cancer? Do you do total prophylactic gastrectomy in the absence of a family history of gastrectomy and in the presence of a laboratory test result that's actually a variant of unknown significance where we don't traditionally do surgery? This discrepancy between different laboratories is not that uncommon. In fact, it's found in about 25% of cases. This was a study published in JCO by Dr. Balmania and a bit collaboration from us. And in 11% of those patients, there was a change in potential clinical recommendations based on how the laboratory assess that particular variant. So these are some of the challenges that we are facing with multi-gene testing. The resources that we use for help with this are the prompt registry inside ClinVar, which help to quantify these variants as pathogenic versus benign. So just in summary, in pancreas cancer, I think we're moving towards universal germline genetic testing. I think it's going to be here in the next 1 to 2 years. For colorectal cancer, certainly all patients need to be tested. There are a number of new colon cancer-associated genes where I think multi-gene testing is certainly reasonable to apply. It's also important to note that with the increasing prevalence of colon cancer in young patients, the majority of these young onset colon cancers are not explained by known cancer predisposition genes or syndromes, and I just want to highlight this to you because it really doesn't explain the rise in colon cancer prevalence in the U.S. Multi-gene testing is certainly appropriate in some settings that I pointed out with the limitations that we discussed, and there are a lot of ongoing studies looking for new genes in unexplained families and in unexplained families with colonic polyposis. Just want to thank all my colleagues for their help. Thank you.